Zio, our cardiac arrhythmia diagnostic tool, supports in-clinic practices. And some of the outcomes that we're seeing in the real world in the NHS using our AI algorithm to help detect different types of arrhythmias. So, really, why does cardiac monitoring matter? I could talk for hours about cardiac monitoring, but really let's look at population health needs. And I think it's something that we haven't quite touched on yet, so I'm glad to be able to sort of share with you how we're marrying up the requirements and the needs of population health and ensuring that we can help sustain a more sustainable NHS. So the figures are pretty stark, right? When we look at cardiac disease and cardiac need within a population, 7.6 million patients in the UK are estimated to have heart or circulatory disease. And when we look really into England, and specifically around AF, which is the most common form of arrhythmia, 2.5% of the population are estimated to have AF. If you have AF, you are 5 times more likely to have a stroke. And a stroke means that you're really costing the NHS up to £3 billion a year, with the addition of £4 billion in lost profitability or productivity or disability in formal care, let alone the personal implications of having a stroke for yourself and your family. Now, we touched on it, and Max said it eloquently earlier, around the pressures on the NHS system with regards to hospital beds, ambulances, but backlog, waitlist times, and this is a real feature at the minute in terms of this data stat here from the NHS from NHS England. Over 330,000 people are currently on the waiting list in the NHS for cardiac appointments alone. So this is a real need here where AI can really start to help address some of these unmet needs in the NHS. So cardiac monitoring, it's the gateway. It's the gateway to achieving more accurate diagnosis, referral and treatment for those patients. You have a pool of population of patients undiagnosed, and 2.5 of those are AF patients. Without the adequate cardiac monitoring, you don't get a quick and effective diagnosis, and you can't put those patients on a treatment pathway as fast as possible. So, the current standard of care is a bit of a barrier. The Holter monitor, which is an antiquated system, 40-odd years old, and it really is a challenge to get this accurate diagnosis of the NHS needs in a timely manner. 3 out of 4 Holter and event patients do not get a diagnosis at the first test. In fact, freedom of information that we have received show that on average, patients cycle around the NHS system maximum 3 times. So they're going to their GP, they're being referred to their secondary care unit, not getting a diagnosis, being sent back home and then presenting again into primary care. And this is up to 3 times. The cost on the NHS, operationally, financially, and clinically for that patient is huge with not achieving. And the reason that the Holter, the current standard of traditional monitoring system, is inefficient is because it typically tends to monitor for a short period of time, 24 to 48 hours. Patient experience is poor. You typically have a box that's around your neck or attached to your belt, and there's lots of leads and wires. It's restricted for patients. It's a short monitoring period, and it doesn't allow them to go about their daily activity. You're expecting that arrhythmia to happen within the 24 to 48 hours, and that's not necessarily the case. Physician and staff satisfaction is known as a delayed time to diagnosis because you're not monitoring for a longer period of time, you're not capturing potentially that arrhythmia, and again, you're cycling around. And all of this is costing resource and inefficient workflows. Clinical outcomes. Missing the diagnosis, again, delaying the time to treatment. We know it's critical that these patients are diagnosed as fast as possible to help support or to reduce the downstream effects of potentially having a catastrophic stroke. And again, cost of care. If we're delaying treatment, we're not able to get these patients on the treatment pathway that they need as soon as possible, then there's an increased cost of care. And with the inefficient workflows, it means that those hospital systems are having to have repeat testing, we're having to use antiquated systems that are not, quite frankly, available at the time when they need them. So why Zio? Zio was the first technology to go through NICE recommendation as part of their digital health tech pilot, and this assessed technology, specific AI technologies, for the use and recommendation within the NHS for widespread. we also, in the same year, were fortunate enough to be the recipients of the first round of the AI Award by NHSX at the time, which is now the AI Lab, right? So we were sort of championed through the AI Lab as one of the most promising AI technologies. At that latter stage, and Pritesh said it earlier, only that 1/5, I think it was that you mentioned, of those mature technologies make it through. So we were honoured to be a category 4 of the AI Awards. So we're proving the following. We're proving that we're improving patient experience. We have a device, there's a picture later, with no needs, no wires, and it's optimised to allow patients to continue with their daily activities with minimal disruption whilst we can maximise the data that's being collected on this device. We improve physician and staff satisfaction and workflows. The resources are readily available, so you can be there in the clinic. They're not having to wait and bring patients back in again and taking up more resources and producing a far more efficient service. Improved your clinical outcomes. Using all the data that we have stored on our device, and again I'll take you through this, means that we have more information to make more of an accurate detection of that arrhythmia. For the clinician to diagnose, and Maureen said it earlier, and Pritesh as well, about the use of the clinician in this, and we are a detection tool where the diagnosis is still put onto the clinician. And again, we're showing that we're reducing the cost of care because we have a more efficient workflow. So our device is monitored for up to 14 days, and as I said before, a Holter monitor typically is 24 to 48 hours of monitoring. It's a short period of time. If you're monitoring for up to 20 to 48 hours, you're missing over 50% of symptomatic arrhythmias. These are arrhythmias that you are feeling symptoms, palpitations, dizziness. There are so many more patients that are asymptomatic. So this is just your symptomatic population. So by monitoring for longer, you have more data available to you to make a more accurate and efficient diagnosis. And this is our device here, which was born out of Stanford Biodesign. And again, it was designed to address the unmet need of a longer-term monitor. It allows the patients to go about their daily activity, but it collects continuously data, heart rhythm data, for up to 14 days uninterrupted. This means that we're able to produce a clinically actionable report from all of that data for our clinicians. So, not all AI is created equal, and Pritesh said it earlier, and we've all sort of said the same thing. You have machine learning, expert learning, you've got deep learning. It's not all created equal, it's not all validated in the same way. But when you look at the quality of the AI algorithm with Zio, and you look at the amount of data that's being put into that algorithm, the quality and quantity of that is key, and I think Pritesh said it in his first presentation about what goes into the algorithm, and quality and quantity of that data is really key. And we have over 4 million patients, 1 billion hours of heart rate data, and our service is validated by over 35 peer-reviewed publications. The AI for Zio allows us to scale this service across an NHS system. It means that we can consistently, reliably help clinicians diagnose time and time again at scale across large populations. But we have a human element to our service, which we will spoke about today. So all of that data collected is assessed by our AI algorithm, but to make that clinically actionable, we have to have a human eye which helps curate the report. So every single patient report is curated with our cardiac physiologists in the office that help to produce a clinically actionable result. 99.9% of clinicians agree with the finding of our results, our report, meaning that this is a trusted service that's developed not only just by AI, but also has the human second eye over our reporting. We're a remote service. Again, this is the causing of some of the workflow issues that Max spoke about earlier. Patients don't need to come back into hospital to have their Holter removed. They simply remove it at home, reducing the need to come back into hospital. Consultations can happen over the phone remotely with patients because, again, they don't need to be brought back into hospital, reducing the need for that outpatient appointment. So it can be a completely remote service for patients. All this is great, but what does it mean in clinical practice? So as part of the AI Award, Zio is being evaluated for real-world evidence, operationally and financially. This is to help back up some of our initial recommendation. So what it's showing already is using our AI algorithm and expediting that patient care. For example, here at Liverpool Heart and Chest Hospital, and this is data presented from ESC only this summer, only this August. It says referral to report, so i.e. the time it takes for that clinician to say you need a Zio, to receiving the report so they can diagnose, is reduced from 46 days to 21 days. We've also got 62% reduction in ILR utility. Now, an ILR is implantable loop recorder. This is quite an invasive and costly procedure, and so we're able to show some efficiencies financially and operationally there. And our arrhythmia detection increased threefold compared to that of our Holter. And that's a cardiology pathway. When we look at the stroke pathway, we're looking at 74% reduction in repeat follow-up tests. And this is again because we've got a far more efficient workflow. We can diagnose and help clinicians diagnose for the first time, rather than having to bring them in for repeat testing. The referral to report reduced from 60 days to 19 days. And in some cases, at Barts particularly, we were seeing that even though they were brought back in to have their results, actually when they got back into clinic, their results weren't available. And so they were sent back home again, waiting again further for their diagnosis. And a 59% reduction in repeat tests. So clinically, we are already seeing the benefits of our AI algorithm and our AI-enabled service within the NHS system. But I'm going to circle back around really to help tie it all together, because I think there's some really interesting themes around predictive analytics. I think industry has a wealth of data and information that could help support population health and population health need, and predicting what perhaps population and ICS might want to look at. Putting care back with the patients and helping those primary care physicians to look at how we might support patients in making those care decisions. I think we are already seeing, as part of Zio, that there is a huge benefit to AI technology within the NHS. And one of the biggest challenges that we find as a company is being able to support wider spread adoption of proven technology within the system. And so that's where
Thanks very much to all the speakers. I just want to ask them to come and sit up here and take some questions if possible.
Data is absolutely pivotal to how we operate our service, but we also are fundamentally of the ethics that this is private information, patient information. But in order for us to access the NHS and get widespread adoption, we have gone through the rigour that proves that we are complying to all the necessary requirements and continue to do so from Zio's perspective.
Yeah, I mean, I wasn't being personal.
No, it's fine.
I just think generally, do you think there needs to be more safeguarding?
So a lot of the way that these AI models will work is that it stays on-prem, which means that data is hosted by your NHS organisation or your GP, and it never leaves. So it's pseudo-anonymised in terms of a pipeline, in terms of how it goes into a model. So actually the data that an AI model or a machine is looking at is non-identifiable, it's not even patient data, it's just numbers and figures. And when the clever process is that when that goes back into the pipeline, back onto Prem or into your hospital trust, that's when it turns back into Mr. Joe Boggs, Max Fowler, and all of the patient identifiable identifiable information. Luckily, Google, who couldn't be here tonight, actually got in big trouble with this at the Royal Free. So I think the industry learned a lot from the early mistakes of some of the bigger tech giants.
So if I come in, first of all, Healthly doesn't retain data, so doesn't actually apply. But from my background, I'm the former chair of the Royal College of GPs and I chair the Professional Medical Standards Body. And it's a completely pertinent question that's been completely pertinent for at least 20 years, if not 25, and we haven't really got an answer yet. And basically, it's a question of trust. And for very good reasons, the Royal Free example being one, and there have been others, and there have also been times where there's been an explicit intention to sell on patient data. The trust isn't there, I think, with citizens and certainly with professionals. Now, there have been advances in this area. I was telling Bryce earlier on that Ben Goldie, Professor Ben Goldie, did a really helpful review setting out principles for the extraction and use of data in ways which should be trusted. That did get a lot of traction with a lot of communities, and it may well give us a way forward here. Because without that way forward, I think 20 years' time we'll still be asking the same questions. There still wouldn't be the trust. It's a wicked problem. It's really difficult to solve.
So just to kind of add on to that, I think to answer your question, no, I'm not confident, to be honest. I think in an environment where you're moving fast, there's first to market advantages, there's more of a risk that things will go wrong. Unfortunately, there are examples where it's happened in the past, and that doesn't mean it won't happen again, and each bad example erodes trust, as Maureen rightly says. There are glimmers of things being different, so I think it's Guy's and St Thomas's NHS Trust, they've set up a platform, I can't remember it's the right one, FLIP, I think it's called, Federated Learning Interoperability Platform, which basically does, as Maureen kind of mentioned, it creates a safe place for, so instead of the data going to the software goes to the data, in essence, and it has a safe place to do that. And so you don't share data with other parties, in essence, and hopefully if this is scaled out, you put the software to the data, you take the software away again, and the data isn't at risk of being shared. That's the goal. It's still early stages.
Hi. Do you think, just wondering, do you think the COVID pandemic made the NHS more aware of the need to use data strategically, and do you think it's getting enough resources put into it in the NHS, or do you think it needs more?
I mean, I've gone through quite a big reorganisation, NHS digital and data, but yeah, so I think, unfortunately, events in history often accelerate the need to change, and the NHS did a massive kind of push into investment in data science, and is continuing to do so. So I think it was one of those things where we kind of might have done 10 years work in about 10 weeks, but that's not really slowing up. It's definitely an area for investment and continued development, and I can see that it is a focus for them to make sure they're investing in these kind of new innovations, definitely.
I think it's fair to say that actually public health epidemiology in the UK is and has been really excellent, world leading. Part of the problem is they've never been, until recently, were never funded properly. It was, and trying to keep programs going from year to year and build on it's been hugely difficult. But I think part of the reason why Max's company was able to do what it did is almost certainly drawing on the techniques and the years of data that the public health community have. I have to say it's a very hidden asset, but even before COVID, if when we get a flu outbreak, the graphs appear showing what the peaks over whenever, and actually from the Royal College of GPs Surveillance Centre, which was run by the public health epidemiologists. But I have first-hand experience of sweat and blood getting funding for that, and maybe now the necessity of this information has been painfully learned by Lords and Masters. It might get the funding it needs.
And there's definitely been far more initiatives that would help the adoption of AI technology on the back of COVID. We've got the likes of the AI Award, which was obviously in 2020, and since then they've had separate rounds. We've also got separate divisions within the NHS, and specifically the AHSN network have been fantastic at really showcasing some of the work they're doing regionally. So definitely seen an increase during COVID, and we hope that continues as we move forward, but there are definitely mechanisms now in place for better adoption.
Okay, so question at the back then.
Shouldn't we then move to an opt-out model rather than an opt-in model for using your data for medical research?
So I think you do have that. So I think when you're admitted into hospital, it's part of your consenting that your data will be used in a trustworthy way. And I think that encompasses that.
So yeah, that's pretty spot on. You may recall, I think, was it last year, GP for data planning research purposes, the GP data opt-out is basically the process that we all automatically opted in, and you have to actively opt out. And when you do opt out, that is generally for service planning and research purposes, but for your direct care, it's still going to be used.
That's a question at Becky Nicole.
Hi, yeah, so this might be for Maureen actually, more specifically if I may. I was interested in what you were saying about actually quite a high percentage of GP caseload, shall we say, could actually be self-care managed at home, and that people aren't sure whether they should see the GP or not, and what they need. I was wondering, the use of your algorithm there, your Healthly algorithm, to what extent has that reduced these, shall we call them, unnecessary GP visits? I'm not quite sure if I'm defining that right. I'm not sure if I can data that at all.
There is no data. I mean, Healthly is a product that's available globally. We're not in the NHS. We're not in any system as such, so that you could do a study that would look at that. One would like to think that if people were better supported in self-care and pre-primary care, that it would reduce the pressure on other parts of the system. But I am not aware of any studies so far that show that, and it would be wonderful to have that research.
And I'm particularly interested because my research is looking at antimicrobial resistance and unnecessary prescribing, inappropriate prescribing. And one of the things that I found recently, I mean, this is totally new, is one aspect of my findings in recent times, is most parents, a huge percentage of the GP's caseload is going to be young children, usually the upper respiratory problems. And a lot of those actually can probably get them
I can't quite hear you. Can you say
Oh,
that?
sorry, not those upper respiratory problems,
Yeah.
just the self-care.
Yeah.
And that parents say they just don't know. With a young child, they don't know, they can't communicate that with an adult for starters, and they don't know which symptoms and severity of symptoms require a GP visit and possibly require antibiotics.
Yeah.
There's a huge need there to have something.
Absolutely, I completely agree. Healthily at the moment, and I think most of the symptom checkers don't yet deal with people under the age of 16. And there's reasons for that, as in it's inherently riskier. But we think we can. Our head of our medical team is actually a paediatrician. We've looked at it, and it's something that's on our roadmap. So we think we can do it. We have to do it safely. You have to have the trust. If you lose the trust, it's a disaster. I do think that should be a direction of travel. What I will say, in my 30-odd years as a GP, isn't quite that long, but anyway, it's a long time, trying to convince parents that their child does not need an antibiotic is one of the most difficult things to do. One thing about COVID, maybe people now start to realise there's a difference between a virus and a bacteria. Nobody ever did before, including, if I may say, journalists. Not you guys, obviously, but that maybe that's a step forward. But antimicrobial resistance is a huge problem. I saw picked up the other day that actually the target for GPs to reduce their antibiotic prescribing has been beaten by several weeks. So British GPs have actually done a good job in bringing it down. But it's a huge issue, and we do need to support parents in making the right decisions for the children. Yeah.
I think it's a very tired parent, I would say. It might be worth looking at home testing and point-of-care diagnostics. So there's technologies being rolled out in pharmacists that can help advise whether antibiotics would be useful or not, and then it would get released by the pharmacist instead of the GP having to actively be involved. Not on all cases, but it will.
Except, that's right, except that if you then tell the mum that it is a bacterial infection, they will want an antibiotic. Whereas the vast majority of them, even bacterial ones, still don't need an antibiotic. So that's an issue as well.
Yes. Yeah. Thank you.
Anyone else? Jerome?
Talking about encouraging patients to take more care of themselves and of their health, which I think would be a pretty good idea. But one of the things I don't think I think is particularly controversial is saying that GPs and most medical people know very little about nutrition and lifestyle things and the benefits of them and how they might be applied and the rest of it. Is that a bit of, I mean, there are quite a lot of people who are active on social media and around. Depending on your position, you describe them as quacks and idiots, or you say they're actually rather useful and know quite a lot and they could be brought in. I just wonder how big data, or does it have any relevance to the idea of let's look at what patients' basic deficiencies are, or problems, or things they're doing in their life which are not making them healthy, and is that kind of stuff recorded, and then you can see whether it makes a difference or not?
Yeah, so I think it feeds into this idea of population health. So really that's about picking out strategic directions for investment that's going to return that investment through healthy populations. And as much as you maybe can't use AI to make people eat healthier, you can definitely look at kind of poverty and deprivation rates across the population to actually pick out areas of strategic investment and education to improve the population of that region. So I think that's something that you can get from data.
But I mean, sorry to interrupt, but there might be quite a lot of value from finding out whether reducing the amount of saturated fat you take makes any difference to heart disease. This is a battle that's been going on for sort of 40 years. AI would seem to be one quite good way of possibly settling it rather than it hanging around. I mean, we're still drinking low-fat milk in Greece that makes a difference.
So I don't think AI can give you accountability. When you go to a GP, I mean, you can turn your phone off, you can turn your notifications off. What the AI can do, and it helps, and there are apps that do this in terms of food diaries, it can let you take a picture of your plate and give you an idea of basically if you're eating unhealthily or healthily, or if your diet's improving.
Probably be rather better than food intake questionnaires, what we're eating over the last 6 months.
I think it's a great question. I'm not aware of work that is going on, but it may well be. definitely a huge public health issue. It would be great to have the data, it would be great to be able to use it, but you know, I don't know that the gender up there that I'm aware of.
Any other questions?
So I'm a writer, but I trained as a doctor again 30 years ago, so it's really interesting being there, you know, sort of my experience with medicine in the 90s and then sort of now. And it seems, you know, so when I trained in orthopaedics, and when you looked at an image in the 90s, it was crap. It was just snow. And you look at them now, and it's, you know, in theatres, and it's better than the best X-ray. So just in that, as you were saying, this sort of living memory, the living memory of this now has sort of constituted. And it seems to me that everyone's very saying, oh, we still need doctors and we still need people to have a little look. We're not going, it's sort of farcical, isn't it? You know, I mean, to me it seems like that, and I'm not saying this, I'm not saying this as a thing, I mean, it's as a good thing. It seems like, you know, feed this data into a machine, kick it out and say, you know, this is your diagnostic. I mean, we've known for years that algorithmic medicine following algorithms is much more accurate than doctors kind of nuancing their experience and everything else, you know, the diagnostic outcomes and the treatment protocols and everything else, you know, and that's why guidelines were involved in inventing. And the sort of, I mean, to me it seems like, you know, there's a sort of play here. Your stuff sounds more like technology rather than big data, you know, sort of looking at hearts and eyes is clever imaging, whereas let's look at, you know, how people move around and like Google picked up there's no smell thing for COVID as a symptom. Just seems to me strikes as a sort of fantastic use of AI. You know, we've learned because we've looked at huge amounts of data and we've learned, and medicine is built for AI as far as I can see. It's just the perfect. You know, you learn. You know, and as soon as you can work out how to transcribe doctors' handwriting, the NHS, I'm sure, is the biggest source of data, of raw data that you can just then feed in as the biggest learning experience. So what, I mean, what's your sort of time? I mean, what can you see happening? I hear what's happening now. It's always, I think it's amazing. I think it's so the way of medicine. But surely it has to be like the car industry. Don't worry, we'll all still have you engineers. If suddenly there's like 3 people on the floor and robots zipping around doing all the work.
Maybe in orthopaedics. I mean, why not? AI and technology are great where you get value from them, and then there are other things at which they're useless. So sitting holding somebody's hand, you know, who's dying, and listening to all the problems they've got and formulating with them a plan to, you know, that's not going to be any clever bit of tech. That's human. It's still medicine, but it's a different human bit of medicine as opposed to machines.
But you need a 9-year medical training or a 6-year nursing training to have to be humanly empathetic.
Actually, in terms of the medical bit, you know, the human bit, no, but the medical bit, yes. What was it going to be? Interesting example about the loss of smell in COVID. It was actually picked up by the ENT guys first. It was picked up by doctors noticing it because they were getting patients referred to them because they'd lost their sense of smell. So they've raised this, is there something going on here? And then the data was looked at. Google, the Zoe app, they were very quick in picking that up, the Zoe team. For me, it's a good example of the humans and the